Hello, my name is Marie Kreuger and I will talk about posterior fossa trajectories using the Leksell Vantage stereotactic system. I will first talk about the advantages and limitations of the Leksell Vantage frame and also explain what a lateral right and a lateral left approach is. And I will then explain how we can place the frame using landmarks only, and then how we can place it using a frame simulation with a planning software. And then in the end, I will walk you through a few case examples and then a quick summary. So let's start with the advantages and the limitations. As you know, the new frame is quite different from the old G frame. And the main difference is that it is less flexible because all the components of the frame itself are completely fixed. However, when looking at the advantages, its main advantage is that it is very robust due to the lack of this flexibility actually that we used to have. It has a stable arc setup, the X and the Y are sterile, the ring coordinates are easy to read, and there is a subscale that allows us to program 0.1 millimeters. It has an easy access to the airway so that the anesthetists really like it, and it also has a friendlier design so that the patients really like it. And finally, you basically cannot attach anything the wrong way. The major limitation, however, is that there are no adjustments possible. So the side poles are fixed, there is an additional upper arc, and there's also a frame attachment ring that is fixed to the frame itself. That gives us a biopsy window for the posterior fossa of 7 × 10 centimeters. Now, to be fair, posterior fossa approaches are always difficult, no matter what frame you use. Here you can see one example for the G frame, where the authors flipped the frame upside down and then used a conversion system to get feasible coordinates. This is certainly a very innovative approach, but at the same time quite complex. Here's another example that shows that if you want to reach lesions from a more lateral angle, you have to rotate the frame laterally. And this was necessary and possible with the old G frame, and that is also what we need to do with the Vantage frame, as you will see soon. The other limitations are the ring and the arc angle. And this video here shows you how the ring angle is limited. So here you can see how the arc will actually bump into the attachment ring or the attachment holder. And you can also see how the guide holder is limited by the side poles. There are two different ways of attaching the arc. There's the lateral right approach, which we usually use here. And then if you flip the arc around, you will get the lateral left approach. And this approach gives you a little bit more leeway in terms of your ring angle and can be quite useful for the posterior fossa. However, as you can see, you can also bump into the attachment holder if you come from very medial. So that is something to take into consideration. So taking all of this together, the most important step when using the Vantage frame for the posterior fossa is to plan the frame placement. And there are two different ways, and I will start with the less technical one. But first of all, we need to clarify a few basics. So there are 3 degrees of freedom: the roll, the pitch, and the jaw. And if you look at the upper row, you can see that if you place the frame like you normally would, it would collide with your trajectory. So we usually have to do 2 adjustments. Regarding the pitch, we have to rotate the frame so that the upper part comes up and so that the angle between the trajectory and the frame is less than 180 degrees. And then the second step is to rotate the frame so that the entry point is further towards the middle of the window, so that we don't clash into the side poles. So before placing the frame, it is very important to know where the entry point, the target point, and the trajectory are in relation to the surface of the patient's skin. And it's good to have a look at the scans beforehand and to identify landmarks like the earlobe, the ear canal, or the eye to guide you as to how to phrase the frame. So here's an example. We can see that the blue target point projects just behind the earlobe, slightly above the ear canal. And we can also see that the blue entry point projects at the level of the ear canal, and it is 3.5 centimeters away from the midline. So we can mark both points and draw a line, which is our trajectory. And now we know we need to place the frame. So this is an example with a dummy where we do this on our dummy. So we know roughly that the target is above the ear canal and behind the earlobe, and we know that the entry point is roughly at the level of the ear canal. And we've measured the 3.5 centimeters from the midline, and now we can mark the dot here, and then we can connect these two dots to get our trajectory. So now we want to place the frame with an angle that is less than 180 degrees between the frame and the trajectory. So here you can see that it is roughly parallel to the frame, but ideally the trajectory has a slightly smaller angle. But this should actually work, right? So we're coming a little bit from up down with our trajectory. You can also see how I rotated the frame so that the entry point is at least 2 centimeters away from the side poles and the upper poles. And now I attach the Y and the Z. So now when we place our arc system with a lateral right approach, we can see that it'll just work because it's almost parallel. So this is a feasible trajectory now. And you can see that we can get to our trajectory here because we have rotated the frame far enough medially here. So I can advance the guide holder. So we have published this, including tables that show you the feasible ring and arc angles for the most common X, Y, and Z, both for the lateral right and for the lateral left approach. And the second way of planning the frame placement is by using a virtual approach. Again, this is published here in this paper, but I will walk you through it in the next video later on. The way it works is that you fuse a CT to the patient's MRI, and it's important that the CT has the frame and the head box on, so that you get stereotactic coordinates. Now, this doesn't have to be the patient's own CT. It can be any CT or a phantom CT, because all you're interested in is overlaying the frame onto the patient's MRI. So in the first example, you can see that if you place the frame normally without any rotation, you will have a ring and an arc that is not programmable. So now you can virtually rotate the frame by changing the jaw and the pitch angle, as we've seen before, and then you can check if that gives you a ring and arc coordinates that you can actually program. And now here is a video that demonstrates this approach. So first we need to get a phantom CT scan. Again, you don't have to do that. You could just use any patient CT with a head box on. But then the next step is to segment the frame as an object, as you can see here. Now, Elekta also has a template, and you could use that, but if you don't have that, you can just manually segment it the way that it is shown here. And that will then allow you to see how the frame placement will look like in 3D on your patient's anatomy. Now, the next step is to plan your entry point and your target exactly the way you would. And I wouldn't make any compromises at this point. And then we have to fuse the CT to the patient's own MRI. And if we don't adjust the frame placement, you can already see here, if you look at this trajectory, that will most likely bump into the side pole. So now we localize our CT head box to get the coordinates. And now we can see that neither the lateral right nor the lateral left approach would be feasible. So we have to change the trajectory by adjusting the pitch and the jaw angle. And now you can already see here, if you look at the orange trajectory, how the entry point is more towards the middle part of the frame. And now we get a feasible coordinate for the arc, but not for the ring with these X, Y, and Z coordinates. So we have to make further adjustments to that angle. And now with these further adjustments, we can see that the ring angle is now below 180, which is usually feasible. And now you can print that so that you can see what the placement should look like on your patient and use that in the OR or when you place the frame the next day. So I would recommend to first mark the points of your pins and also mark the target, the entry point, and then draw the trajectory. And it helps to have one or at least one or even two pairs of extra hands to fix the frame exactly the way you want it, especially if the patient is asleep. And now we get the actual CT of the patient with the frame on that day. We fuse the CT to the patient's MRI, and then we check whether the coordinates are feasible. And I used to do that with an extra frame. However, that was just until we had created these tables from the publication. But I would always recommend you try it with a frame before you do it the first time. And now here you can see the setup in the OR. We usually operate it on the patients in a semi-sitting position. And so once you've got feasible coordinates, everything after that is really just easy sailing from there. You just program the frame and then you can do your biopsy or whatever you need to do through the posterior fossa. And now if you have small children, it can help to add an extra screw because of the extreme rotation that makes this whole approach a bit less stable. However, I don't know if it really helps, but it certainly gives you a better feeling. So now I would like to walk you through a few case examples. And I will start with things to consider when planning the trajectory. And as a rule of thumb, you should try to plan your trajectory as straight and as medial as possible. So here is one example where you can see that the direction from the entry point to the target is quite extreme, and therefore we require a frame placement with an extreme rotation both regarding the jaw and the pitch angle. And this is a concrete patient example. I think that was the first patient I have operated with the Vantage for the posterior fossa. So it was a quite extreme angle, since I didn't know all the tricks at that point. And it was possible though, but it can be difficult to get a CT scan actually, because you have to bend the neck quite a lot. So in this case, it's really worth looking at the planning to see whether it's possible to come from a more medial angle and to have a less extreme ring angle, simply because that allows you to place the frame with less extreme angles, as you can see in this example here. You can also see that this is the same lesion as before, but we simply only chose a more medial and less angled trajectory, and now the frame placement is much less extreme. If you have to choose such extreme angles and you cannot change the trajectory, so if you have to come from very lateral or with a large ring angle, it is usually better to use a lateral left approach, and it can also be possible to enter lateral to the side poles. But let's look at the extreme ring angles first. In this example, you can see that we are bumping into the attachment ring and the attachment holder using the lateral right approach on the left picture. So in these cases, if you flip the frame and change to a lateral left approach, you can see that you have much more wiggle room and you can have larger ring angles without bumping into anything. Here you can see that in this case we had to come from very lateral, and it's actually possible to come lateral to the side pole, and then you only have to rotate the frame slightly to the opposite side instead of an extreme rotation to come through the midline. Again, this was a concrete example of a patient where you can see how the frame is only rotated slightly because we came lateral to the side pole, so in between the ring and the side pole. Next, I would like to discuss the question whether we should do a lateral right or a lateral left approach. And I would always plan for a lateral right approach, because then you can use the lateral left as a default. Because most often the frame ends up too high and the ring angle is a bit too big, so more than 180 degrees. And in both cases, you can prevent having to replace the frame by simply switching to a lateral left approach. So it's always worth testing if it's not easier to do the trajectory with a lateral left approach. And then finally, just a few words on the why. Again, as a rule of thumb, the smaller the Y, the easier, because the smaller the Y, the further away you are from your attachment ring, and especially from the attachment holder, which will give you more freedom in terms of your ring angle. So now that brings me to my summary. I hope I was able to show you the advantages of the Vantage frames, as discussed earlier. However, it is less flexible, but posterior fossa approaches are possible, but you have to be aware of the limitations and you really have to plan the frame placement very well. And with this, I would like to thank you for your attention.